I would like to start by welcoming everyone. We are very delighted and thrilled to resume this series after our brief pause. Of course, your expertise, your questions, and of course your contribution in the case discussion is very valid, and we encourage that. I know that in this version, unfortunately, we don't have the chat section, but please feel free to participate in your thought and your question through the question and answer section. As well, whoever is interested in talking, I can unmute you at any time. Just please raise your hand. We have here Andrew Margos. Of course, would you like, okay, I think it was by mistake. Anyway, but please feel free, to participate in today's session. As usual, we start our session by introducing our panelists for today. So today we have two distinguished panelists or toxicologists from the region. And for those who are regularly attending the MENATOX clinical rounds, I'm sure you are familiar and you know them. But for those who are joining us for the first time, I would like to introduce them to you. We have Dr. Suad Suleimani, who's an emergency medicine and a medical toxicologist at the Armed Forces Hospital Emergency Department in Oman. She had her medical toxicology fellowship from Emory University, United States. And as well, she is a double board certified in emergency medicine from the Omani Medical Specialty Board and from the Saudi board as well. And she's BLS, ACLS, and HLS instructor. Welcome, Dr. Suad.
Thank you, Dr. Afra, and welcome everyone. Thank you.
And thank you, Dr. Saad. I would like to present our second panelist. Our second panelist is Dr. Lara. Lara Suleimani is an emergency medicine consultant at Rouge Hospital in Dubai. She's a core faculty and adjunct faculty in both Mohammed bin Rashid University and Dubai Medical College. She is an Arab board and European board certified in emergency medicine. She is also member of the Royal College of Emergency Medicine Physician in UK. She holds a diploma in medical toxicologist from Cardiff University, UK. And she has a professional diploma in health leaderships and innovation from Rochester Institution of Technology from Dubai. Welcome, Dr. Lara.
Hi, thank you very much, Dr. Afra and the team for this chance and opportunity.
Sure. Actually, thank you both of you, Lara and Dr. Suad, for committing to this webinar. So I would like to start our first presentation. Our first presentation is led by or presented by Dr. Shamma. So we have Dr. Shamma. Dr. Shamma Alhajeri, she's an emergency medicine resident, PGY3 from SKMC, Sheikh Khalifa Medical City, Abu Dhabi. Can you see my screen? Sorry. So I think now the setup is done. Okay. So Dr. Shamma, as we said, Dr. Shamma Alhajeri, she's an emergency medicine resident, PGY. She's almost actually PGY4, to be honest. She finished her third year of residency from Sheikh Khalifa Medical City. Welcome, Dr. Shamma.
Thank you, Dr. Afra, and thank you, everyone. Shall I start the presentation?
Yes.
Okay. Good evening, everyone. I'm going to start our presentation titled with Lactate Gone Rogue. We'll go to the next slide. So while I was in the ER, we saw a 29-year-old female brought by the ambulance with altered mental state, agitated. That was preceded by an argument, a fight with her spouse. Patient was, the ambulance brought her after a call from her friend while she was in, she called her friend while she was in distress, shouting, screaming, and found laying unresponsive shortly after the call at her apartment. Bedside, no EMS report were available. So this next, There's a comment that on arrival to ED, maybe not. The nurses noticed abnormal movement. They thought maybe it's aggressive behavior or seizure activity, which resolved spontaneously without any intervention, before even being seen by the physician. Next slide. So since the patient wasn't given us history, she was not communicating, we started with examination. Her vitals, temperature 36.8, respiratory rate 19, blood pressure systolic 105 over 64 diastolic, saturation 100, heart rate 89. A primary assessment, airway was maintained. There was some incomprehensible sounds, breathing, bilateral air entry, symmetrical chest expansion, no added sounds. Circulation, blood pressure, heart rate were maintained, intact pulses. She was warm and dry. GCS of 7, E was 1, V2, M4. She was not responsive, pupil reactive bilaterally and constricted. We can go to the next slide. Okay. General exam, she was unconscious, not responding to painful stimuli. We mentioned warm and dry skin, pupils reactive bilaterally. Oral mucosa was dry. On neurological exam, there was no hyperreflexia or clonus. Otherwise, the exam was within normal limits. Can go to the next slide. So we can stop here and ask the attendees or the panel. We can get some differential diagnosis so far.
Please feel free to use the question and answer bar so we can,
Yeah. What's the first thing that pops in your mind? What do you think? We can go back.
yes.
Anyone? Should I?
Is that we can 1 second. We have here the question and answer. Okay. So we have antipsychotic. Okay, so what do you mean by antipsychotic? Do you mean the antipsychotic like patient was using antipsychotic medication or antipsychotic, overdose? Good, good process of thinking. So first or second generation of antipsychotic. Okay, you are considering this. Good.
Mm-hmm.
We have here opioid poisoning. Okay, that's good. So you are thinking also about opioid overdose. However, like few things in the physical examination wouldn't go with the physical examination, and let's say the vital signs wouldn't go with the opioid poisoning. Which are these things? For example, if you look to the vital signs and the physical examination in this patient. We have here anticholinergic, which is good. Okay, you're thinking about anticholinergic. Drug-induced movement disorder. Okay, so you mean like because there are so many drugs with overdose, they can actually induce convulsion and the seizure. So there's like so many drugs. Most of the drugs, like an overdose, they can cause that. What else? Anyone would like to add?
Anyone has thought about any infectious causes that we usually miss in ED?
Good, Dr. Lara, yes. We have here early serotonin syndrome. Good. Okay, good process of thinking. Hypoglycemia. Good. Hypoglycemia should be actually part of your ABC, and I would say part of your vital, like checking the blood sugar, because it can mimic many things and it can cause seizure by itself. I agree with you. So we have encephalitis. Good. And we have, what was her glucose level? Okay, Dr. Shamma, what was her glucose level?
It was within normal limits. Hyperglycemic. She was 17 millimole.
Okay, yeah, she was hyperglycemic. Okay.
Sorry, Dr. Shamma, you said she was hyperglycemic, 17 millimole, you said? I couldn't hear
Yes.
the number.
Yes,
Okay.
it was actually 17 millimole.
approximately in milligram per deciliter, how much?
Let's convert it quickly. It is by multiplying it with
306. It would be 306 if converted.
Okay, so if we are thinking of with the hyperglycemia and agitation, anything can come to the mind? The
DK.
differential DK or even hyper, yani it's not the number for hyperosmolar, but one of the things that we need to consider to also hyperosmolar.
Okay, good. So any suggestion, what Dr. Lara just said, you would think about? So we have here like, Amani, she's saying hemodynamically going against opioid, which I agree with her. For a patient who's coming with respiratory rate of 19 and the pupils are not really constructed, it's less likely that this is an opioid overdose. But still, you can, still you should be part of your differential, I would say. We have here like in the context of that fighting with her like husband, the flavor goes with self-poisoning, which I agree with you. Yes, it could be, but still we cannot rule out others. And also like keep in mind that acute psychosis can present with similar presentation as well. So we can resume now the case, and we'll go through going the case through us going the case. We'll have more discussion.
Okay, we can go back to the previous slide, Doctor. So
Yes.
in this case, we worked her up with all the differentials we had. For example, meningitis, encephalitis, intoxication. She could be having a metabolic disorder, sepsis, etc. These are the first slide of her labs. I will give you a second to look through them, and I can interpret them. And this is the second slide. Okay, so the inflammatory markers were slightly elevated. Also, you can look at here. Otherwise, in the CBC and differentials were okay. CRP was normal, so this goes against infection if you think about infection. We can go to the next slide where we have the chemistry labs. Her sodium was high, 148. She's hypernatremic, basically. Her bicarb was 8. Her anion gap was 34. Creatinine 91. Yeah, and we can, where is it? Yeah, can look through the blood gas. You can see the VBG. pH was 6.97. That's super acidotic. CO2 was 47.7, elevated here, and bicarb is only 11. So she's experiencing acidosis in this case. Her glucose, as I mentioned earlier, was 17, which is hyperglycemic. She's hypernatremic. Lactate is 22. So usually this lactate is super high. I rarely saw like this before. Yeah. So Afra, you want to add any comments? Okay, we can go to the next slide.
So just before we're going to the next slide, Dr. Lara or Dr. Saad, you would like to comment on this findings? Of course, just
So-
keep in mind that VBG was the first things was done for this patient. So VBG was obtained initially. Of course, the rest of the lab test was, sent to lab, and the result came later on.
Yeah, so one of the things in the VBG that's striking us, like for example, if she is hyperglycemic, again, we tend to label patients as drug intoxication easily. We need to consider like DKA in such patients with severe acidosis. One of the things of toxins, I believe, we tend to ignore is aspirin. So aspirin, they can come with altered mental status. And in such a VBG, we have to consider aspirin. This is, I believe that we should include it in our differential, not only anticholinergic or stimulants or other things.
I agree with you, Dr. Lara.
Just adding to what Lara has said is that taking this clinical contents and a young patient who does not have from the initial vitals a clear toxidromic features like of, for example, sympathatomimetic, anticholinergic. It's not really very clear from the initial vitals and the initial examination, like it fit into very typical toxidromic features. But the clinical contents of being young, had a social conflict with the husband, may raise this the drug intoxication as a differential, yes, but not a top differential. As Dr. Lara mentioned, I would consider like the other causes, metabolic, CNS, infection, taking all the metabolic. But if we think from drug point of view, high lactic acidosis, that severe and that bad of lactate more than 20, I would probably put a drug higher in the list. Like so many drugs that may cause a high lactic acidosis. Metformin-induced lactic acidosis, cyanide, take in consideration like other toxins that affecting the mitochondria, like carbon monoxide, cyanide, nitric acid, and then hydrogen sulfide. All of these are can be accessible, and then rodenticides can be anything that is accessible and may cause a high lactic acidosis. Salicylate should be in the top as well of a drug-induced lactic acidosis. So I think we have a lot of medication that may cause and affect the cellular mechanism by different mechanisms and may cause that high significant high lactate.
I agree with you, Dr. Saad. And here we have also one of the differential, as Camelia was commenting, metabolic acidosis with high lactate could be metformin. One of the should be one of your differential. The metformin as well. As well what Dr. Saad she was mentioning, all of these drugs can cause high metabolic acidosis with high lactate. Of course, now we are talking about and this like in the scenario of overdose, but as Dr. Larsh was emphasizing, we should also think about non-toxic causes such as DKA, sepsis, encephalitis, what else? Like it could be thyrotoxicosis. So many things also to consider as well. Things that could cause agitated patient with abnormal lab, let's say. Okay, so
adding to that is that the patient had abnormal movement, which is a skeletal muscle and increasing anaerobic metabolism, which may contribute secondary to a high lactic acid,
yes,
from any other cause, like taking seizure or hyperthermia, CNS infection. All of these can cause such presentation.
yes, I agree. We can proceed, Dr. Shamma.
Okay, so after the labs we did there's extra calculations we have done. Ending up, we know about it. The osmolality was 334. That was shown later on in the labs. Osmolar gap was calculated 8.6. Glucose, we know, was 17. Creatine 91, urea 9, CK 163. We can go to the next slide.
I just want to pause you here, Shamma. So basically, approaching this patient, the physician who saw this patient, called me. They weren't sure. They thought this could be tox related. So the differential that I gave them was, to consider, to be honest, metformin, salicylic acid, and less likely, but also to consider toxic alcohol. So if we'll talk about toxic alcohol, so many things can fit with toxic alcohol in this patient, and the things that can fit with toxic alcohol in this patient as well is that the patient came with altered mental status, severe metabolic acidosis with high anion gap. And then when it comes to the osmolar gap, so in osmolar gap, usually most of the toxic alcohol, when they are consumed in the beginning, before they get fully metabolized, they will cause high osmolar gap. However, while they get metabolized and the parent compound like the methanol and ethylene glycol get metabolized to its metabolites form, the osmolar gap will start to normalize. One thing. The other things is that also which could be thing to debate regarding the osmolar gap in this patient. The osmolar gap in this patient, you can consider it normal, but there's so many studies talks about the range of the osmolar gap, which actually it has long or like a wide range, which it actually almost from -14 up to like 14. And they always argue that what if the patient osmolar gap, their baseline of the osmolar gap was minus, let's say, 10. So would we consider like 8.6 is a high osmolar gap for this patient? This is another things I mean to argue regarding this patient. And also, as I said, that osmolar gap, it happens when you have the parent compound circulating in the blood system, such as the ethanol, ethylene glycol, methanol, diethylene glycol, isopropanol, all of these. So, of course, I would like to ask Dr. Suad, Dr. Lara, if you want to contribute on this.
I would
Yeah.
totally agree with what you just said, Dr. Afra, regarding the high osmolar gap. And this always need to be taken in consideration if you're clinically suspecting or the history is giving you a suspicion of toxic alcohol. Don't depend on the gaps, like either a smaller gap or anion gap, because you may catch the patient at any metabolic state. Either you have high osmoles in the blood, so at that initial period where the osmoles are active, you may catch him there, but maybe you catch him late, and then probably like the osmolar gap is low, and then by that time a high metabolic acidosis will appear. So
Yeah.
clinical, and if you highly suspect it, probably yes, I'll go with testing of toxic alcohol.
Yeah, and usually, like to establish the osmolar gap and calculate it, the labs that you need it, they will not come easily or fast, and fast enough to determine or wait for them to determine the diagnosis or at least act upon your differential. But anion gap, okay, we can get it in the VBG. It's a stat test. For me, usually, we used to study this mud piles, cat mud piles as a differential for high anion gap metabolic acidosis. But recently, I've been really into the term of cults, which is KULTS. It's mainly for it looks for the differential of the causes of high anion gap, so you'll know the general cause, and then you look at what can cause this. So like ketones, uremia, lactic acid, toxins, and salicylate. So if you think in a broad way, then you start to narrow it, you will have lesser chances than in missing important diagnoses like toxic alcohol, which usually many patients, they will deny being exposed to it, especially if they will use toxic alcohol as a substitute of ethanol. When they drink alcohol, they drink methanol instead of ethanol. Some of them, they will be ashamed and they will not tell you. We had a patient, we found out that he used methanol very late when he presented with blindness. But if he said from the beginning, because initially he came with eye complaint, visual loss, and he did not give the history of abusing or using methanol until late in the stage when everything has been ruled out and he's been investigated, but it was too late to save him. Even dialysis at that time, it was too late for him.
Yes, because I think the damage that happens to the eye is almost irreversible.
Exactly.
Yeah, when it comes to methanol, unfortunately. I'm not sure that if the patient survived or not, Dr. Lara. Your patient, did he survive?
He survived, and he's alive, but unfortunately he's blind.
Yeah, he's blind. Yes, unfortunately. We have here a question for Dr. Shamma. I see the lactate was performed on the POCT analysis. Was a lactate run in the main lab?
There was one later on when the patient was in ICU.
And did you remember what was the reading?
Uh,
Was it
it
before, yes?
lab lactate was only in ICU. It was later on, like the second day, maybe. I don't
Okay.
remember exactly, but it was lower than 22. Like after
Okay.
the management, it got better there.
Yes. Okay, so we can resume. Can go to
Okay.
next.
So we, for this patient, we did an ACG. Anyone wants to contribute, or shall I just go through it?
You can go through it. It's fine.
Okay. So basically, the ECG looks normal sinus rhythm. The only abnormality here was a prolonged QT. So corrected was 508. Yeah. Next slide. We did, because altered mental state, we did CT head, and also we did a chest X-ray. Both were within normal limits. We ruled out a bleed. There's no pneumonia as a source of infection there. We can go to the next slide. Okay. As a regular thing, sometimes we do it. The urine tox was done, was within normal limits. Other labs otherwise were also within normal limits, other than the ones that I showed. So now we limited our differentials. We called toxicology and ICU. Can we go to the next slide? اللي بعد هذه. I'll come back. Yeah. So we called toxicology on call. They told us to consider salicylate toxicity, TSA, metformin, or a combination of any of the above. To start with 3 vials of sodium bicarb in the fluids, and if the pH is below 7 and lactate more than 20 to consider dialysis, which we did. And our patient fits this criteria. So we can go to the slide before. We also called.
I just
Yes.
want to pause here. Regarding the sodium bicarb, it was recommended not because of the ECG changes. The ECG didn't have any like widening QRS. It's just because the patient she was in severe, metabolic acidosis, and it was just bridging till we get her to the dialysis. That's why we recommended the sodium bicarb.
Mhm.
Yes.
So in the yes.
To this, yes.
So in the ER, she received 2 liters of IV fluids. Initially, she was given 2 milligram of lorazepam, and she was also given 0.4 milligram of naloxone. Given 3 vials of sodium bicarb, 50 each. She was intubated, hence she was altered mental state, and she was worsening. Yes, a central line was applied for dialysis. ICU admitted her. She went for CRRT dialysis. Yeah, next slide. Okay.
So we can, if I'm gonna just pause briefly for Dr. Lara and Dr. Suad if you want to add anything on the management.
I believe it was well managed addressing the other differentials. Securing the airway was really important in such cases. It's not only because of the GCS of 7, because we know that the number is not that of clearly, and it's okay, GC7 is very low, but it's not in medical causes, not like in trauma causes. But in such case, we have to secure the airway. And sometimes we have one of the benefits of early intubation of those patients is early, if we consider toxicological causes, early decontamination in such patient, or considering dialysis in those patients. So securing the airway early was a good option and choice.
Yes, I agree with you. Dr. Saad, yes.
Yes, so basically the treatment is mainly supportive in drug-induced lactic acidosis. I just have a comment on the sodium bicarb. As Dr. Afra said, sodium bicarb here is not for a prolonged QT, don't mistake that. And even sodium bicarb for drug-induced lactic acidosis is a controversial area, like not all lactic, unless it's very severe list, like 6.9 sometimes, or really very severe lactic acid, acidosis. Sodium bicarb would be advocated in such cases as any other ICU indication. But for specifically to affect the mechanism of action, you have to know the mechanism of toxicity that has contributed into the lactic acidosis if it's drug-induced, because it's basically like a cellular damage, direct cellular damage to the, affecting the citric acid cycle, or, the transport chain, like in salicylate toxicity, the electron transport chain. So it's a different mechanism, basically. So there are certain indications for sodium bicarb, yes, and it's a bit of controversial topic in toxicology, like giving it for drug-induced lactic acidosis. But I guess which would work here more is the dialysis. fluid resuscitation, supportive management rather than sodium bicarb alone.
I agree with you. Yes. The thing is that the rationale was behind giving the sodium bicarb, as you said, because this was severe metabolic acidosis. And remember that, I mean, acidosis is one of the causes of cardiac arrest, just like it was bridging. But as Dr. Saad said, always remember that you need to address the underlying cause of the acidosis rather than just treating it with sodium bicarb. So it was literally just bridging till we get the dialysis line in and start patient on dialysis. So can resume.
So when she was admitted inpatient under ICU, they also consulted toxicology again, thinking about the ethanol, glycol, etc. They advised them to give fomepizole, a loading dose of 15 milligram per kg over 30 minutes, with maintenance of 10 milligram per kg over 30 minutes every 4 hours during the CRRT, minimum 24 hours. They said, and to get the levels of ethylene glycol and methanol. Unfortunately, they were missed in this case, these levels. And to continue until acidosis and systemic toxicity resolved. We can go to the next slide. And they also recommended doing an echo, the dialysis, correct electrolyte, hourly ECG, cardiac monitoring, and calculate the osmolar gap with and send the urine assessment for calcium oxalate, which was negative. We can go to the next. Okay, so this patient progressed. So she was admitted to the ICU. She stayed there for 3 days. With this supportive management, she was improving. She was stable. She was extubated, then moved to a regular ward under IM for 2 days, and she was fine and went home. There was more history was given to us from the notes of these from following her up on the system. She when she woke up, she told them she had chronic back pain and she takes regular painkillers. And that day she came to the ER. She was brought to the ER. She had an encounter of domestic abuse by her spouse. She was assaulted, so she took 2 sleeping pills and 10 naproxen tablets. Unfortunately, it was not documented the doses and of these medications. Yes, and we can go to the next slide.
I think we can proceed, and then maybe at the end we can just pause for discussion. Yes.
Okay, sure. So, as the case shows, the patient admitted she took naproxen 10 pills, unknown dose. There was case reports about this, like NSAID causing similar case presentation as our patient had, severe metabolic acidosis after acute naproxen sodium ingestion. It's a rare thing. This case report was very old, in 1989. Yeah. But
Yes, I just want to comment, because we already reached like our the end of our presentation. In this case, this was very rare presentation of naproxen, overdose. For me, this was the first case to encounter. Even when like the patient wake up and she reported taking or ingesting naproxen, I thought maybe the history wasn't very accurate, the history that she gave. And I tried to search like literature review and check if there's any case report for this. Actually, this was the only case report we could find. And interestingly, many of the presentation of the patient was similar to this case. I would like, to open the floor for Dr. Alara or Dr. Suad. Have you been encountered with, naproxen or NSAID, with this such presentation?
Never. For us, aside from like, if we can say of aspirin, such a case, no, even mefaminic acid, the one we saw was mainly with the seizure, but like severe
Yes.
metabolic acidosis, no.
Yeah, because this was very interesting, honestly. It was something new to learn.
Yes.
Yeah,
So,
exactly.
so even the dose that she has given, like 10 tablet of naproxen, is not that, to cause, because basically like NSAIDs, metabolic acidosis, we reach that stage in really, really very severe toxicity, like a
And massive overdose.
significant overdose. So I guess there are other contributing factors in this case it's not only the naproxen. maybe like maybe there are other contributing factors to the
I
severe.
wonder if she kind of mutation in her, liver enzymes that cause her to has that severe effect with 10 tablets.
Yes,
Because in this case, the reported case, it was actually 50 tablet of 250 milligram of naproxen was ingested, which approximately, if you think about it, it will be around like 12 gram. But I wonder, did our patient ingested like 500 milligram of naproxen 10 tablet, which will be equal around to what? 5,000 gram?
Which is like,
Yeah, unfortunately, I couldn't find. It wasn't documented how much she took in dosage, only the pills. Plus, she's chronically using painkillers. So I don't know if that contributed to that too.
maybe she was having underlying chronic kidney disease before that make it, and it got worse with the ingestion. We never know. Maybe she had another co-ingestion that she did not declare it, because many patients, they want.
Yeah, it was documented that she took also some sleeping pills. What were they? It was not also documented. So, and that was her first visit to our emergency. We didn't have any prior labs or anything on her before.
Mhm.
Maybe that's also like the co-ingestion may contribute, because I could not really correlate the prolonged QT into naproxen specifically. It may be seen in some NSAIDs like Trolac and some other medication like tramadol, like and NSAIDs, not NSAIDs, I mean celecoxib sometimes, and diclofenac. Yes, you may see like prolonged QT, but specifically with naproxen, I'm not sure like we can see a prolonged QT. So maybe the other co-injection has contributed into that prolonged QT as well. But I guess what the management really here made a difference, because sometimes you need really to throw all the guns. Like what was done in this case, even adding, famotidine, considering toxic alcohol for lactic acidosis was, I guess, right. Sometimes you need to do that because all testing for toxic alcohol will take long time. So you may need to throw all guns and treat everything, like considering a high drug-induced high lactic acidosis, and give a good supportive management, and that was the key in this case.
Thank you. Thank you so much.
There's a question.
Uh,
Someone wrote, any proposed mechanism of lactic acidosis in naproxen?
Actually, reading the paper itself, it said it's unclear but this is very old paper, to be honest. I checked like the FDA, leaflet of naproxen. According to the leaflet of naproxen, rare complications such as metabolic acidosis, can happen with naproxen. But this is like rare, I'm not sure exactly if either because basically naproxen by itself, it considered a weak acid. Could it be by itself or it is metabolite? It could be it is metabolite. But exactly how it caused the lactic acidosis, it can cause the metabolic acidosis. But I would say here in this scenario, the metabolic acidosis is mainly because of the high lactate, Well, so I'm not sure, honestly, Dr. Iqdan. Yes. We need to wrap up the case so we can proceed to our next presenter.
Yeah.
Thank you all. Thank you, Dr. Lara, and thank you, Dr. Suad. Thank you, Dr. Shamma, for a great presentation. So we'll go to our next presenter. Our next presenter, just second. So we have our next presenter is can you see my screen?
Yes, can you hear me? Can you hear my
Yeah.
voice clear?
Yes, our next presenter, just to introduce you, Dr. Shahla. So Dr. Shahla, she is an emergency medicine resident, PGY1 from SKMC as well, in Sheikh Khalifa Medical City, Abu Dhabi. Welcome, Dr. Shahla.
Hi, good afternoon. So for today's presentation, I hope it would be easy and simple and goes well. So we'll go on. So I'll be presenting a case that we encountered in our ED. So this is we got a patient. He's a 28 years old male with unknown past medical history. Go on with the slides, please. We only got an ambulance call. They found a patient who's altered mental status, and he was found at the bus station outside in the heat. It was afternoon, 2 p.m. afternoon in the bus station outside in the hot. EMS, they reported that the patient was very agitated on the scene and he was hitting other people, and suddenly he collapsed and then he is having abnormal body movement. So per the ambulance, this is what we got as an info before he arrives. Moving on, vitals that were reported by the EMS on arrival, they said everything, patient was vitally stable, but only his temperature was reported as 40. Uh, Once the patient arrived to our ED, we got this set of vital. Patient was hypotensive of 66 over 25. His heart rate was 170. His respiratory rate was 17, and he was sitting well on room air initially, and then we applied the oxygen mask. His temperature was 42. And then patient was appearing restless. He was shivering. He was moaning with incomprehensible sounds. His body was all stiff. He was diaphoretic, severely sweating. His pupils were minimally reactive, dilated pupils. Chest was clear bilateral. He had normal heart sounds, no murmurs, and then abdomen, no left lower limb. This is for the physical examination and vitals upon ED arrival. Moving on, according to these, yeah.
Yes, you can proceed. Yeah.
So according to what we have initially, and with these vitals, and then this physical examination, what would differentials would you put on your mind in this patient, and how would you approach him?
Okay, so we have here, neuroleptic malignant syndrome, one of the differential we have. Okay, so we have here serotogenic. Okay, good. So you're thinking about serotonin. We have SSRI, okay, medication overdose. Okay, can we think about like non-toxic causes of this presentation as well? I know that everyone immediately looking for or checking of toxic causes, but I mean, it's very important also in our approach to think about non-toxic causes. We have heat stroke. Good, excellent. Heat stroke should be one of your initial differential.
Thyrotoxicosis.
Good, thyrotoxicosis. Anyone else would like to contribute? Okay, so Dr. Shahla, we can resume, and then we
Yeah.
can look for more. Yes.
So basically, when he first came, so we assessed our ABC, and then his airway was intact. We put the non-breather, he was fine, and then CD, and then he was diaphoretic, sweating, everything was fine, no other external findings. So we did first the VBG. So this is what we got. If you have any more differentials, you can add it on the comment. So before I go on with explaining the VBG, because you can see he's having high lactate. He's having hypernatremia, but along with it, there's a mild hyperkalemia. But you can see as well the hemoglobin is high, so you might think because he's diaphoretic, he's sweating, so it might be hemoconcentration, along with the other finding of the electrolytes. Along with this, he's having severe acidosis, and when you look at the CO2 and the bicarb, you would notice that it's a mixed metabolic along with respiratory acidosis, and add to this the high lactate level.
Okay, good. So we can resume.
Yeah, so moving on. So what we did in the resuscitation room, so a patient was intubated as he was agitated, not maintaining his airway, and then this is for the A, and then for the C, he was sweating, shivering. We gave him 3 liters of normal saline. As you just said, one of the differential could be heat stroke because he was outside and he was severely sweating, losing fluid. Before we gave him the normal saline, we just made sure with our ultrasound focus that he's not fluid overloaded, so we don't overload him with fluid and then he goes he crashes more. So focus ultrasound, we did it in the ED. It showed collapsed IVC and hyperdynamic left ventricular function, which means that the patient is severely dehydrated. Central line was inserted as well because one of the differentials in this case, we would think of sepsis. He had high lactate, he was febrile, he was hypotensive, so septic shock could be one of the differentials. Along with this, he was agitated and altered mental status. One of our differentials was CNS infection, meningitis. That's why we got a culture was obtained, and then 1 dose of ceftriaxone were given to the patient. One of the initial management we did in him is external cooling because the patient was the muscle he was having spasticity all over, rigidity, sweating profusely, diaphoretic. We did an external cooling with wet bed sheets, a lot of ice bags over the axilla, groin, and neck. Uh, so moving on, what more labs or investigation you would like to add or to put in this patient according to your differentials?
Feel free to share your thoughts and Q&A, and I mean we can also like allow Dr. Lara, Dr. Suad to tell us their impression. Okay, so we have here someone talking about the infection markers.
Hmm.
We are going to come to that. Yes, Dr. Lara.
So I've seen many, they considered neuroleptic malignant syndrome one of the differential. This patient had any history or anyone was able to obtain any drug history in that patient?
Yes, actually, I was gonna talk about it, but if I spoke about it initially, you would know the diagnosis of this
No
patient.
problem.
That's why we're leaving it to the end.
No problem, we can leave it till the end. So
Yeah,
CT,
CT brain was obtained as well.
okay.
So why Dr. Lara is asking about the drug history? Because when you think about neuroleptic malignant syndrome, I mean, there is 2 category of a drug that can cause this. I mean, the 2 drugs category that can cause this, we have the antipsychotic drug. I mean, drugs by itself can cause that because they inhibit the dopamine neurotransmitter in the brain. And then we have also stopping or decreasing the doses of anti-Parkinsonism drug, which actually stimulate the dopamine in the brain. So these 2 drugs, I mean, either overdose or withdrawal of these drugs can cause neuroleptic malignant syndrome. However, in neuroleptic malignant syndrome, what could goes against that is that it's usually happen gradually, but it should be part of your differential. It doesn't happen acutely. It usually happen gradually. There's like deterioration and movement and mental status and symptoms wise, but good to consider it in one of the differential.
And always we need to have an insulting drug. Yani there is no one who will have neuroleptic malignant syndrome without the exposure to the drugs that will cause the neuroleptic malignant syndrome. So that's why drug history is very important in such patients.
I would just add a young patient with such presentation, initial agitation. Is it the agitation has led to the secondary high lactate and the acidosis and the hyperthermia, or is it the hyperthermia which has led into all these consequences, or it's a drug initially? So it could be like all of these are related to each other. In young patient, yes, probably I would think of like drugs as a differential, but in the top I would keep like hyperthermia, especially in our region, as and heat stroke as a top differential. And the secondary acidosis and high lactate is secondary, could be secondary to this, the metabolic effect of hyperthermia. But if we think about the drugs, again, like hyperthermia, serotonin syndrome, sympathatomimetic, could cause like really a high temperature, such high temperature. Anticholinergic is likely to be like, this high temperature, but probably I'd go with serotonin syndrome, especially with the rigidity that the patient had, and also considering sympathatomimetic as well.
I agree with you. So we can resume.
Okay, so moving on, we have some of the comments. They said CT brain, ECG. ECG showed only sinus tachycardia. CT brain was negative. Chest X-ray was negative as well. Inflammatory marker, CRP was negative. Initially, it was 2. CK, we have it on the slide. It showed 400. Coax was negative as well. So basically, this is his labs. Again, it's showing high sodium. It's showing anion metabolic acidosis. Creatinine level is high. Urea level is high, which might lead us to AKI, especially in his case because he was hypotensive. He was sweating. So we're thinking of AKI due to dehydration. Along with this, he did the TSH, T4, EGFR also was low, which goes with the AKI. Of course, the urine tox, it showed amphetamine was positive, methamphetamine was positive in his case. So moving on. So basically, this patient, in his history, he had a similar presentation about a year ago, which he was treated as a possible neuroleptic malignant syndrome because he was on antipsychotic as he was a schizophrenic patient. He was in ICU that time. He remained in ICU for 1 month for his treatment. Along with this, on ED arrival, once we examined the patient and we did the whole exposure, we found a crystal meth bag in his pocket. And this is a picture of the pocket that we found it in his clothes upon examination. So moving on, so this patient initially we treated him supportively, mainly managing the hyperthermia through the sedation, the agitation. We managed the agitation. Patient was intubated. Hyperthermia was managed mainly by external cooling. Furthermore, he was admitted in the ICU for 2 days, and then he was extubated, and then when he went back to a regular bed in IM, but he stayed there for almost 2 weeks. As the patient, once he was awake, he was awake, alert, but he had some issues with orientation, and they were like, is it like a psychosis due to medication intoxication, or is he really schizophrenic? So he had an assessment, full psychological assessment, psychiatry assessment, and for the whole 2 weeks, and then he was discharged. In the ED, of course, after we gave him the 3 normal saline fluid, his BB improved. Although we inserted a central line, but patient did not require any pressors. That's for the case. Moving on. So the thing is, we think about it, sympathomimetic, especially amphetamines. In his case, the only thing he arrived with tachypneic. He was agitated, altered mental status, diaphoretic, severely sweating, and the pupils were dilated and non-reactive to light, minimally reactive to light. But the only thing was the blood pressure. He presented with hypotensive, so it was a mixed amphetamine overdose toxicity, along with he was dehydrated, with rhabdomyolysis, as he was in the heat. Along with this, moving on, this is his labs before he was discharged. So everything went back to normal. His VBG normalized, his kidney function test all went back to normal. Just a quick overview over the differentials that you need to think when the patient come in with these symptoms, especially if you don't have any past medical history or you didn't have time to open the the chart as the patient is critically ill. So one of the things that we did in our ED is that we considered sepsis. That's why we took culture as the patient was hypotensive. We took culture, we gave antibiotic prophylactically. We did CT, it was negative because patient was altered, agitated, so we don't know if he's having any hemorrhage inside. Hypoglycemia, hyperglycemia patient, in this case, his glucose was 4.9, which is normal. Of course, hyperthermia due to other causes, it's just symptoms. Thyrotoxicosis is one of the causes, pheochromocytoma as well. The toxicological things that we would think about is the sympathomimetic. This includes the cocaine, PCP, anticholinergic agents. But in his clinic, in his clinically, he didn't have the dry skin. He was sweating profusely, if it goes with more sympathomimetic. Of course, serotonin syndrome, NMS would be considered if we knew that the patient is schizophrenic and he was on antipsychotic. We would also include it as one of the differentials. Moving on.
Okay, I just want to pause you here because almost we are wrapping up the case. So basically, this is a young male who presented with, agitation, sweating, high temperatures, hypotensive, tachycardic, right? And I want to ask, this is like a question to the attendees. And this patient, what is the one management that you need to do to save this patient life? This is my question. The most important. Regardless if you know what you are dealing with or not, by only having the vitals and clinical presentations. Okay, so we have here the temperature. I agree with Amani. I mean, managing the high, the like, for example, like what I want you, to go home with is how to manage the hyperthermia. Hyperthermia can cause multi-organ failure, and eventually it can be fatal. So if there's something that you need literally to emphasize in this case for today's presentation is how to manage the hyperthermia in this patient, because this is the only things that would save the patient life. So if you look at the patient labs like previously, you will notice that patient developed AKI, developed high CPK, which goes with rhabdomyolysis, and there was also queries of also seizures with the patient, right? So all of these could be due to the hyperthermia that's happening. So okay, another question to the attendees: how would you cool the patient or manage the hyperthermia? So I can see like you are saying cooling, but what type of cooling do you want to achieve, or what type of cooling you want to do? Okay, good. External cooling. So external cooling is very important. It is your main approach to this patient. Remember, antibiotic has no role. It has no role neither in heat stroke or in any drug or substance induced hyperthermia. So when it comes to hyperthermia, of course, the best methods of cooling is water immersion, where basically you immerse the patient on a tap full of like cold water. The water temperature can vary from like 4 degree up to like 25 degree, but of course the more the water is cold, you're gonna achieve the cooling faster. So this is one method. But however, this method is very challenging. It cannot be done because mainly especially in patient with sick patient who you need to protect the airway. So this method is not really I would say practical. Your other like method that you can use in the ED, which is affordable and practical and doable, is like you have the fan and mist, where basically you mist the patient with like cold water or like room temperature water, and keep a fan over the patient. Of course, you need to to remove externally remove all the clothes. This is another like method. The third method I would say is what we used here, also very effective, as like you wet a bit of sheets, you wet it with cold water, or like let's say like let's say room temperature water, and then you apply it on the patient, and then on top of that you either apply cold packs, cold compression, or ice bags. Depend whatever is available in your emergency department. You need to apply these, and where exactly? You need to apply these on large vessels. Where's the large vessels? As we have in the axillary, in the neck, and in the femoral region or inguinal region. So, I mean, I would like to ask like Dr. Suad and Dr. Lara, I mean, if they want to add anything before we wrap up the case.
Thank you for the case, Dr. Shahla. Just few comments about methamphetamines. As how much you will think about hyperthermia in our region, like as a top differential diagnosis, I want you to keep in mind that methamphetamine is the most common illicit drug in our region. So you may encounter like such case. It's not uncommon to see such presentation. It depends on where you work exactly, but it's the commonest, the illicit drug, and people can easily get into an overdose of methamphetamines. Methamphetamines below, they are phenyl ethylamines, which is a chemical structure with the backbone of aromatic ring and 2 carbon side chains and terminal amines. And little bit of change in that carbon backbone make the other, the commonly named different methamphetamine groups, like, crystal, what we call crystal meth, crank, speed, molly, ecstasy, MDMA, all of these are methamphetamines. Clinical presentation is basically like a sympathetomimetic. So here, just one addition, a urine drug screen is a commonly, performed test in emergency if you're suspecting illicit drug. I want you to keep in mind that urine drug screen that we use in our hospitals is an immunoassay, which has a lot of cross-reactivity and a lot of false positive and negative. It's not specific and not sensitive. So it may give you a clue for the diagnosis, yes, but I would advise you will not depend on it and forget the other differential. So you have to rule out the other differential if you're suspecting sympathetomimetic, and don't depend on the urine drug screen because it's non-sensitive, non-specific. The sensitive and specific test for the urine drug screen is the gas chromatography. And this is available only in very specialized lab, and if you suspect it or for, very specific indications, like really you need to send it like medical legal, or you need to confirm really the diagnosis in a comatose patient. But we use this, that's why it's called a urine drug screen. It's just a screen, it's non-specific and non-sensitive. So don't depend on your diagnosis on the urine drug screen. Yes, you may use it as a clue, but don't depend on it. It has a lot of cross-reactivity, especially like in methamphetamines, where even cough and cold drugs may be positive. Pseudoephedrine may be positive. A lot of other drugs, may turn to be positive, or even MDMA might turn to be negative in a urine drug screen. So don't depend on it. Just make it like, as may give you a clue, yes, but don't forget the other differential diagnosis. And just emphasizing on what Dr. Afra has said, management, early cooling is the key. Early cooling is the key in hyperthermia. This is the prognosis. So I will insist really on early cooling as a management, regardless of what is the diagnosis.
Thank you so much. It was very enlightening, Dr. Suad. Yes, Dr. Lara.
Thank you, Dr. Saad. Thank you, Afra. And thank you for the cases, Dr. Shahla. Just remember that also regarding amphetamine, that it's also used as a treatment for ADHD, and we have a lot of patients who are on what they call it Concerta. And many of them, they come with overdose or drug-to-drug interactions. We recently had one with sympathomimetic picture after he was initiated on some antipsychotic that were interacting with his amphetamine, and he went into toxicity just because of drug-to-drug interaction. So just keep this in mind. Cooling is the key. And remember, in toxicological hyperthermia, most of the time the hyperthermia is mainly due to muscle contractions. So normal antibiotic will not work on them. We need to cool them by sedation and active and passive cooling. The other thing that dantrolene usually will not work in other than neuroleptic malignant syndrome because it's different mechanism. In hyperthermia and neuroleptic malignant syndrome related to the calcium channels and sarcoplasmic calcium, but the hyperthermic, the other causes are in different mechanisms. So just remember that dantrolene will not work in other causes other than neuroleptic malignant syndrome. So cooling by ice immersion, by a cold saline. Even sometimes you have to put a Foley's catheter and put cold saline through the Foley's catheter. Mist and spray mist and fan and sedation usually are the key for such patients.
Yes, I agree with Dr. Lara. Thank you so much, Dr. Lara, Dr. Suad, because I have to wrap up, the session. We already exceeded the 1 hour. Thank you so much to our presenter, Dr. Shahla and Dr. Shamma. For those who are interested in presenting for the upcoming or the next MENATOX clinical round, please email me through my email. It is drafrasuwaidi@gmail. Thank you all for your attendees. And thank you for our panelist and presenter.
Thank you, everyone.